Hello, everyone, and thank you for viewing Key Indicators for Discharge, Turning to the Data. My name is Brianna Gonsalves, Assistant Director of CTAC. I am joined today by Yvette Kelly, Director of Children's Services and Healthcare Innovation, and Boris Vilgorn, Healthcare Strategy Officer at NYU McSilver. This is a pre-recorded presentation intended to build upon the continued work with Article 31 clinics. Today's discussion is all about discharge policy and practice. We focus on considerations as to why agencies should have a discharge policy in place, including recommendations for best practices in discharge. Since this is a pre-recorded offering, we wanted to make sure you have an opportunity to share your feedback about the topic. We have developed a brief survey, which you can find in the overview section of this page. Please take a moment to share your thoughts and considerations for future trainings on this topic. Lastly, if you have any follow-up questions, please feel free to email us at ctac.info@nyu.edu. Thank you so much again and enjoy.
Hello, this is Yvette Kelly with the Community Technical Assistance Center, and today's presentation will provide an overview of the current challenges facing the behavioral health system and take a look at how strong policies around discharge can serve to mitigate some of these concerns. We will then move on to discuss the elements of a comprehensive discharge policy, talk about best practices in discharge, and then leave you with some key takeaways. So we are currently at a time in which the demand for behavioral health services is increasing across the United States. And at the same time, the behavioral health workforce is experiencing significant staff shortages, a crisis that only seems to be escalating. While this rise in demand demonstrates a recognition of the importance of behavioral health, it also serves to burden an already strapped behavioral health system and challenges the capacity of behavioral health providers to serve individuals in a safe, effective, and competent manner. Additionally, these issues are far reaching and have a rippling effect that result in a number of on ground challenges that agencies need to navigate in real time. One of the areas in which agencies need to be responsive is that of addressing and mitigating access issues. This issue is exacerbated when agencies are unable to attract and retain qualified staff at a rate that is commensurate with current demand. This results in people waiting longer for services, whether it be at the front door or whether it be an existing client who is in need of some additional care. It also impacts an agency's ability to offer specialty services that may have been readily available previously. When access to care is delayed, client satisfaction is reduced and health outcomes are poor. Then there's the direct impact on staff. Not having enough personnel means that existing staff may experience an increase in workload in an attempt to accommodate the agency's and community's needs. When this happens, agencies risk subjecting their staff to stressors that make providers more vulnerable to compassion fatigue, burnout, and secondary traumatic stress. These experiences have been shown to contribute to adverse outcomes for providers to include job dissatisfaction and reduced professional and personal efficacy. Thank you. One of the greatest challenges facing not just behavioral health care, but healthcare in general, is capacity management or management of client flow. Ensuring individuals receive the right care at the right time and the right location is paramount. However, stagnant client flow can upend these efforts and create additional stressors for an agency, such as lengthy wait lists. This also contributes to inefficiency, care delays, additional costs, and inability to meet the local population's needs. That is why it's imperative for agencies to engage in a process of developing comprehensive discharge policies and practices to support not only improved access, but improved staff and client retention as well. So let's discuss how comprehensive discharge policies support access and retention efforts. When there's a discharge policy in place, it provides the staff with a roadmap as to how they should proceed in their day-to-day interactions and highlights what the agency and program expectations are. It supports the provider's decision making as to who may be ready for discharge, either given their progress or circumstance, and importantly, helps the provider in being clear with the individual about the benchmarks associated with a successful discharge from services. And a comprehensive discharge policy allows the provider to increase service capacity by ensuring that only those requiring services are the ones receiving services. So, next, we'll move on to discuss the elements included in a comprehensive discharge policy and areas agencies should consider when developing a new policy or revising an existing policy. Before covering the specific elements of a discharge policy, I wanted to take a moment to just review the core tenets of discharge planning. And although this presentation does not speak to this concept directly, it is important to mention here because these tenets should really inform and be evident in an agency's policy. Discharge planning is an important element and critical activity in the delivery of care for all individuals. And given this, discharge planning should commence upon the individual's admission into a service or program. The discharge plan should continue to be revised and updated during the course of an individual's care as appropriate. Planning should be individualized, comprehensive, and coordinated with other community based services. And the individual and family are and must be considered full partners in the discharge planning process. Again, all of these tenets should be evident in an agency's policy. So, what are the key elements of a discharge policy? One of the first elements is articulating how a provider will determine one's appropriateness for discharge. What metrics and decision-making tools are expected to be deployed? What is the individual and or family's expected trajectory towards discharge, recognizing that nothing is precise, but is there a common denominator that the provider should be looking for here? Are there steps that should be reviewed and or taken to aid a provider in ensuring that an individual is ready for discharge? For example, do you expect that the frequency and intensity of services be reduced prior to an individual's or family's discharge? And what is the protocol if an individual or family is ready to be discharged but continues to require psychiatric services? Do you have a procedure in place that takes this into account? Are you able to provide this service only? And lastly, what community based services do you expect that individuals being discharged from care should be connected to? If you serve a particularly under resourced population, are there community referrals that are expected? So, detailing this information again supports providers in the delivery of quality services. Another element for consideration is providing guidance as to how providers should be assessing level of care. The policy should clearly spell out the criteria for admission, continued care, and discharge. It should also identify the metrics for deciding when and if an individual or family needs either a lower level or higher level of care, along with the process for initiating this change in care when the needs are determined. As behavioral health professionals, we recognize that discharge planning is important in order for individuals to maintain gains achieved during the course of treatment. But we also recognize that there are times when people need to return for a variety of reasons. An agency's discharge policy should also take into account how the program will continue to support the recovery of program participants who are either experiencing a crisis, have new or emergent issues, or are just having difficulty applying the skills learned. Of course, all will require a different approach, but, but by detailing the process for an individual's return to treatment, that can help promote enduring treatment gains. Timelines associated with these expectations should also be addressed. For example, is the nature of the support either different or the same for individuals who have been discharged, say within the last year versus within the last 3 years? And with all policies, these efforts should uh, be documented in some form or fashion. Standards should be identified as to how these efforts get documented in the record and supervision and with the family. Consideration needs to be given to how this information can and will be utilized to improve practice and to develop a complete picture of agency discharge patterns. And so next, I'm going to turn it over to my colleague Boris Vilgorn to walk us through the remainder of our presentation today.
Thank you, Yvette, excuse me, and Brianna. I'll be picking it up from area of leveraging data and the importance to look at the data and incorporate that as to into your policies and procedures. One of the areas that we recommend that agencies think about implementing into their practice is the standardized reporting scheme as it relates to discharge policy. That could include, for example, monthly, quarterly, and annual report. It could be done by agency as a whole, by particular programs that your agency operate or services that you provide. It could be drilled down by supervisor and the staff they oversee, and of course, all the way down to the staff level to indicate the rate of potential discharge or other elements that might be associated with it. So again, understand where the organization, program, staff stand, and which would also leads into some of the expectations that Yvette talked about. Again, some of the key metrics to consider, again, would be individual clinician caseload reflected by proportion of full-time equivalent or FTE, percentage of clients discharged, as I mentioned. Reasons for discharge is important to capture and think about in reporting. For example, identifying most common reasons for discharge and percentages of total discharge. That includes, again, things such as positive discharge, loss to care, and of course, you would need to make sure there's clear definitions of all these reasons and how they're captured in the system. And also considering as related to discharge, looking at the client's, excuse me, average length of stay. We recommend, there's many ways to um, look at the length of stay. One of the ways we recommend to look at is only looking at open active clients and determining how long on an average those individuals have continuously been in stay. And again, you can do this by agency, program, supervisor, or staff to give you a sense of where clients stay, the general data is showing in regards to your population being served. Next slide, please. So continuing with some of the metrics that I've discussed already, you also can look at percentage of active clients against caseload. So for example, clinicians' caseloads, this could mean clients who receive at least one service in the past month versus clients who have not received services within the month. That also starts giving you a sense of who's really active and who's might be on a caseload but need to be revisited or looked at closely in regards to services being provided, because maybe the individual or the family might be indicating by not coming in for services that they are not ready, not done, or there might be other, of course, social determinants of health or other issues that's preventing them. So taking a closer look, not just at a caseload, but also determining how many individuals are actually active. In other examples, clients who attend 50% of their appointments could be counted towards as an active client. That's just one definition that you can use. But as an organization and as a program, you really should think about determining when you say active clients, what does that really mean? Clients' average monthly frequency of service is another metric to consider. No shows. I know a lot of agencies track this, but making sure that it's clearly defined and is part of your metric system. And again, average number and percentage of clients being admitted monthly. That's important to consider, especially compared to average number of clients being discharged as a metric I talked about, and comparing the two, especially if you're discharging, let's say 10 to 20 clients a month, but admitting 20, 30, 40 clients a month, that will quickly as grow the caseloads and quickly overwhelm staff. And again, as kind of Yvette mentioned during her portion, will lead to additional burnout. So understanding both the discharge and the admission would give you a good understanding of where the entire program and agency numbers are heading. Now let's turn our attention to best practices in discharge and follow through some of our thinking and recommendations as it relates to best practices. So to consider some of the best practices to establish a discharge planning team that is reflective of various department service personnel within your agency. So for example, that could include a direct care staff, a supervisor, agency leadership, and again, having a team that really looks at your discharge policy, discharge planning, and making sure that it's collaborative vision around the expectation, and making sure that you have an input, not just from senior and executive staff, but other stakeholders within your organization as well, that develops these corresponding policies and procedures. It's important to establish written protocols, as Yvette mentioned as well, for discharge planning, which includes documentation. It should include utilization review in your discharge conversation, policy and planning, and again, considering who does utilization review, how often. For some programs, there's very strict rules and regulations. Others have a little bit more flexibility around that, but again, making sure they correspond to your overall vision and policy of an organization. And of course, it's always important to provide training to all staff involved in discharge planning to ensure that some degree of uniformity in the implementation of your written protocols, making sure staff understand what the policies are, what are the practices and the procedures as it relates to it. And so it's important to train staff and evaluate whether staff are following those protocol and adhering to the written guidance in addition to the training. As we continue with best practice and discharge, again, it's important to establish or determine who is in your wide network of care providers to whom you'll typically discharge and or refer your clients to. Again, Yvette talked about important documenting that, especially for underserved communities. There might need to be additional connections. So making sure you indicate that, and staff are aware of all those resources that are available, and if resources allow, collect data on outcomes of your discharge procedures. And again, this is not just about if it was a positive discharge or loss to care or what might be the reason. This goes a little bit beyond just indicating the status of the discharge, but also indicating if the goal and purpose of the discharge is being met, and also if the individuals are meeting their goals that they have set during their treatment with your program and your organization. Also, communicating with your team is crucial. So ongoing presentation of data in team meetings, depending on how the structure of your meetings are and what you're able to do, we strongly recommend that you focus providing, being as transparent as possible with your team, and that's providing agency-wide program supervision and staff numbers, as we talked about during the data discussion, and consider only indicating sometimes staff who are above or below program levels and not providing staff specific data. So it might be tricky for some folks, or uncomfortable to list everybody's names and indicate where people stand. So one way, again, that we suggest as considering is maybe just indicating we have X number of staff above and X number of staff below, and not necessarily indicating who they are. However, when you have those individual supervision sessions and discussions, of course, you should definitely, talk about each individual staff and their particular, kind of reports and their numbers as it relates to discharge. Um, and again, this leads very much into expectations and so forth, but also, in addition, being open and upfront with understanding that there are going to be exceptions that exist, and that not everything could be followed exactly, just by numbers. So some exceptions, for example, could be when the program continues to serve a high needs individual who needs a higher level of care, but the transition just cannot occur due to access issues. So understanding that even though a discharge might be appropriate and you're looking to move somebody to a higher level of care, but in meantime continuing to support that individual while you're trying to resolve some of the excess issues that might exist there. And just acknowledging that and making sure that people are not penalized, your staff, because of something that it's out of their control, really. As we continue with best practices in discharge, as I mentioned again, supervision is a crucial component here and can support discharge planning. Again, as I mentioned, reviewing the data with staff is important. Reviewing and assessing the complexity of caseloads is also important. Understanding, the levels and individuals' needs within the caseloads, and frequently reviewing continued care criteria for all cases, and assessing who on clinician's caseload may be ready for discharge. Kind of utilizing standardized metrics that could be determined, and inquiring as to who the clinician would recommend for discharge if they were leaving the agency today. As we know, in a lot of situations we experience, when staff leave, and caseloads get reviewed, a number of individuals at that point get discharged. So kind of, creating that scenario before the individual leaves, kind of thinking through how would they handle that differently is sometimes helpful, in also thinking through potentially who might be ready for discharge. Discussing potential changes in frequency of service. So it doesn't all necessarily have to be, treatment or no treatment being discharged. It could also mean that maybe somebody needs less services. And instead of coming in weekly for therapy, maybe they could come in, every other week or even monthly. Or maybe, as again Yvette mentioned, maybe the individual just needs medication management. And also reviewing potential changes in service array. That means maybe somebody could switch from individual to group, or needs both individual and group, and reviewing that. So even though we're talking predominantly and focus on discharge policies, but I think it's important to also think through not just about fully discharging individuals, but also thinking about the frequency, the array, and so forth, that hopefully will facilitate and guide towards the discharge, and getting folks, to the place where they're, ready to move on. Also utilizing staff feedback. As I've mentioned, creating a group, it's important to have all stakeholders, but also, if through supervision, team meetings, or other ways, not just through developing a team that focuses on discharge policy, is also important to make sure you're hearing staff feedback. And that could include questions like what discharge policies and practices can be improved to make your job easier, and having that discussion from the staff, hearing that from the staff. What can be done to make it easier to admit new clients? We sometimes see that, staff might be reluctant to discharge folks because they understand that opens up opportunities for new individuals to come in. And, there's a lot of concern about additional paperwork, documentation, processes in place that folks, don't look forward to every time there's a new client. So thinking through about how do we, make that component maybe easier for staff, and looking through the assessments, documentation, progress notes, and everything that could be associated. Also asking what isn't working and what is working. I think it's also important to think about that. What needs to be changed? What are your concerns? Are you concerned with liability? We also hear from staff and supervisors that sometimes folks are cautious, or, might not be ready, to talk to the individual and family about discharge because they're concerned about liability. And so really being, again, as open and honest as possible, and making sure the staff provides that feedback in the conversation to better understand, how you as a supervisor or how as an agency could support staff, and what could be done in regards to policies and procedures to support the best practice. So some key takeaways from today's presentation. Again, consider the benefits of having a discharge policy to your agency, which provides clarity to staff and those served, provides guidance for decision making, assists providers in recapturing service capacity. It also leverages the data to get better understanding of patterns by agency, by program, by supervisor, and by staff. It includes discussion about discharge planning as team meetings and supervision session. It solicits staff feedback about the discharge planning and admission experience. And of course, always you want to incorporate that feedback into your policy revision. So this concludes today's presentation. Uh, Thank you for viewing our presentation. As Brianna mentioned, if you have any questions and feedback, please feel free to email us at ctac.info@nyu.edu, and you can always explore additional resources and tools at www.ctacny.org. Thank you.